Very importantly, we have to remember that this patient has diabetes mellitus, and we know that the presence of diabetes in terms of prognosis represents a problem. Somebody with diabetes compared with individuals without diabetes has a 6 years less lifespan compared to the non-diabetic counterparts. And if in addition, the patient has diabetes and an acute MI or history of an acute MI, then the life expectancy is reduced by 12 years. So the presence of diabetes is a key element, and we need to be very aggressive in managing this risk factor. In addition to the specific management of diabetes, we need to make absolutely sure that we are dealing with the dyslipidemia in an appropriate way. So maximum dose of high powerful statins to reach a LDL target, ideally in patients with diabetes below 1.5 millimoles per liter, below 50 milligrams per deciliter. We need to make sure that we are preventing thrombogenesis. This patient is on aspirin, which seems to be reasonably okay. Manage the metabolic issues, the overweight, manage the tension, and importantly, manage properly the hyperglycemia. Management of hyperglycemia is important. And you'll see in this slide how the hazard ratio in individuals with diabetes, type 2 diabetes, increases, particularly mortality, when the hyperglycemia is not well controlled. People who on oral agents are managed to keep the HbA1c in between 7 and 8 do a lot better than individuals in whom we are unable to control the HbA1c. And something we tend to neglect or forget about is the fact that mortality after an acute myocardial infarction is equivalent to mortality after episodes of hypoglycemia in patients with type 2 diabetes. This is a very important concept. And this slide shows how mortality at 1 year follow-up is similar after acute MI compared with hypoglycemic episodes. And this is, we're talking about individuals in the region of 65 years of age, similar to the patient we are discussing today. So in this particular patient, we have to be careful not only to keep the hyperglycemia at bay, we have to make sure that we don't cause hypoglycemia when we treat this patient. So in order to manage these risk factors and this patient was given amlodipine, a calcium channel blocker, to lower the blood pressure, in addition to the ramipril. We gave her very strict diet and, very importantly, support in clinic. And this is critical, providing support to the patient. When we actually have patients in whom we ask sort of to change drastically the lifestyle, we need to provide them with support. We increased the dose of statin, the atorvastatin, to 80 milligrams, and added ezetimibe to reduce the cholesterol to reach the target level I mentioned before. And we discussed this patient's HbA1c improve further. So one option was to refer them back to the diabetologist for the use of GLT-2 inhibitors, which we know improve outcome. And we also, from a ischemic perspective, thought about ranolazine, but I'll come back to this in a minute. So in facing this patient, what we thought was, okay, we know that this patient has obstructive coronary disease for which he had the stent. Stent is working apart, it's not blocked. She does have symptoms which suggest that there is a functional cause for ischemic angina with emotions, the variable threshold for angina. So she might have either coronary artery spasm, which we documented angiographically with the injection of acetylcholine, and we also speculated that she could have microvascular dysfunction because of the angina on exertion, despite having a patent stent. And we documented with the cardiac MRI perfusion scan that she had coronary microvascular dysfunction. So in this case, we have a combination of three mechanisms: the obstructive coronary artery disease, the coronary vasospasm, and the microvascular dysfunction. So thinking about the pathophysiology when we analyze the symptoms of the patient is very important because it guides the treatment. The European European Society of Cardiology guidelines, the latest guidelines in 2019, tell us that in choosing anti-anginal agents, we need to consider the individual patient's profile, the comorbidities, the potential drug interactions, and very importantly, patient preference. So we have to inform the patient what kind of drug we're going to use, what side effects they may experience, and what are we going to achieve with the drugs. And of course, we have to use drugs that are available to us. All the guidelines, and I'll come back to this in a minute, tell us, well, start with a beta blocker or a calcium channel blocker. So that's first choice. But there is no evidence, no randomized control trials actually endorsing this very strong recommendation in the guidelines. But anyway, people start everything with treatment with the standard medications. However, the recent guidelines have actually highlighted the fact that there are other drugs that we don't use normally as a first line, which can be extremely important in managing patients. And they have given a 2A recommendation to the use of other medications depending on the kind of patient we're treating. And with the 2B recommendation, there is a very important concept, which is that some of these agents, like ranolazine, nicorandil, ivabradine, trimetazidine, can become first-line drugs depending on the heart rate of the patient, the blood pressure, the tolerance to other medications. So let's bear this in mind, because we may have drugs which we don't use normally, which can become key for the management of the patient or of a patient like ours. So in our case, this patient had been treated with a beta blocker, which did not solve the problem. On the contrary, she got more angina at rest and with emotions. So it is quite reasonable to start a calcium channel blocker in this patient, which is what we did. The blood pressure tended to go a bit low, so we couldn't use a very large dose of these agents. And we still had the problem of treating the angina pectoris. So we moved on to the sort of the recommendation that is linked to the low blood pressure patients. So if somebody with low blood pressure, we use either a low dose beta blockage, which was the case in this patient, and added a calcium channel blocker. And the calcium channel blocker here was important for the blood pressure, for the coronary artery spasm. And then immediately we thought, well, we should give this patient ranolazine, because in dealing with somebody with relatively low blood pressure, with diabetes, with microvascular dysfunction, ranolazine comes into play practically as a first-line agent. So in this slide, I have actually summarized a little bit what I said right now. I mean, how can we improve the symptoms of myocardial ischemia in this patient with these so many mechanisms leading to the angina? Which agents should we try, bearing in mind that she has the mechanism that I described? So a rational approach based on the guidelines would be to consider ranolazine.